Hello everyone, thank you for organizing committee of SCONA, Society for Computational Fluid Dynamics in Nose and Airway, to give our team this great opportunity to present our systematic review. So our team as authors, we performed a systematic review about the role of CFD in the assessment and management of obstructive sleep apnea patients. Obstructive sleep apnea is a condition in which upper airway collapses during sleep. As a result of frequent episodes of apnea and hypopnea, patients experience a variety of symptoms such as morning headaches, daytime sleepiness, and snoring, and consequently it affects his quality of life. It was found OSA results in an increased risk of motor car accidents and cardiovascular problems in long term. The first line diagnosis of OSA includes polysomnography or sleep studies, which records the body activities and vital signs during sleep. There is another tool is called drug-induced sedation endoscopy DISE, which represents a widespread tool for evaluation of upper airway during sedation to know exactly which side of upper airway which causes collapse during sleep. So the use of computational fluid dynamics has been used in clinical trials to investigate its use as a tool for diagnosis of OSA. CFD uses a digital computers to produce quantitative measures of the fluid flow phenomena. This technology helps to determine flow characteristics within the upper airway. Due to the use of CFD being relatively new, we are going to present a brief of systematic review was done to the current literature of its rule. Prisma guidelines for systematic reviews and meta-analysis were followed. A systematic literature review of all papers involving computational fluid dynamics and obstructive sleep apnea were included. A search was done on PubMed and Embase by searching of computational fluid dynamics and obstructive sleep apnea. After exclusion of some studies, resulting in 131 publishing papers, majority of these papers were done on adult OSA patients. 19 studies were done in pediatric population. After review of all of these papers, we found some information we assume it would be helpful in the field of OSA. Multiple studies have used CFD to understand the pathophysiology of OSA. At the first, increased flow velocity and reduced static pressure can itself increase the airway collapsibility. During inhalation, negative pressure caused by vortices drives significant narrowing of the pharynx. This narrowing is strongly dependent on whether inhalation occurred through the nostrils. The nasopharyngeal coronal sectional area was found to be significantly smaller in OSA patients, while airflow velocity was significantly higher and pressure showed no difference. There was a variation in the pharyngeal size found to be flow limiting between nasopharynx, retropalatal pharynx, and oropharyngeal and epiglottis level. The most collapsible area is the velopharynx, which has maximum air velocity and lowest pressure. CFD based on dynamic MRI volume imaging and advanced segmentation can non-invasively reveal local airway mechanical properties during sleep. CFD results during nasal and oral breathing reveal that oral breathing is a primary condition leading to pharyngeal airway collapse. A strong correlation between nasal resistance and pharyngeal pressure was found, suggesting that the nose plays main role in the pathogenesis of obstructive sleep apnea condition. Morphology of airway influences pressure changes and distribution of air particles. It was observed that the diameter of airway particles increases, the location of highest particle deposit will shift to the anterior part of upper airway. the local deposition fractions prove that the upper airway plays a significant role in filtering large microparticles of air. Other different studies have used CFD to investigate interventions, mostly surgeries, as treatments for OSA. Nasal surgery can decrease the total resistance of upper airway and increase the nasal airflow volume and subjective sleep quality in patients with OSA and nasal obstruction. The altered airflow characteristics might contribute to the post-operative reduction of the pharyngeal collapse in a subset of OSA patients. Post-intervention, CFD showed increased average pressure, decreased average velocity and pressure drop in all cross sections, and largely decreased airflow resistance and maximum velocity entirely in the airway. The oropharynx and nasopharynx were obviously expanded, the collapsibility of the upper airways was reduced, and the patency was sustained. The change in the square root of pharyngeal pressure drop before and after mandibular advancement treatment had a strong relationship with the treatment response. CVD can be used to predict treatment outcome of surgical intervention, and certain anatomical and flow characteristics can be considered as markers for success. Whenever the upper airway morphology is adequately corrected, resulting in an enlargement of upper airway volume and decrease of upper airway resistance, the manifestation of OSA is less severe. CFD can be used to predicting the efficiency of uvulopalatopharyngoplasty, which is the common operation for treating of obstructive sleep apnea patients. CFD can also identify non-successful treatment. For example, the opening of nasopharynx and oropharynx was intended to relieve breathing difficulties. However, the increase in muscular effort to hold the airway open and the wider range of airway motion offsets the benefit of having a more patent airway. Further interventions that have been investigating with CFD analysis include genioglottal advancement procedure or maxillomandibular osteotomies were discussed in other studies. As a conclusion, CFD simulation workflows have been developed to analyze the severity of sleep apnea, in which the airway walls play an important role. Information about different regions of upper airways can be identified, such as the primary site. Studies have also used CFD to gauge the severity of the disease. Certain validation studies prove the reliability of CFD and further supports the use of CFD as a potential tool for understanding of OSA, including comparison with a current gold standard apnea-hypopnea index for assessment of OSA. So as a conclusion, CFD has played a huge role in better understanding of OSA. Currently, it is mostly being used for research. However, studies show that it has a promising diagnostic and therapeutic roles in clinical practice. Thank you for this great opportunity.